Good afternoon. I will be presenting today on the health assessment in refugee camps around Mosul, Iraq. Mosul is the city that has been under the spotlight of the news over the past few years. Since June 2014, the city represented the stronghold of ISIS or Islamic State in Iraq. In August 2016, the Iraqi government and the coalition forces launched a military operation on the east side of the city. As we see on this map, there is the river that is dividing Mosul, and all what is on the right-hand side of the river is the east side of the city. The military operation resumed in the west side in February 2017 and is still ongoing up to date. MSF has been operating in 6 medical facilities by the time of the survey, providing secondary healthcare, primary healthcare, nutrition, and mental health. Like in every war, the civilians are the one to pay, whether with casualties or displacement. The Mosul city counted approximately 1.2 million people, 450,000 from the east and 750,000 from the west. Displacement from Mosul has reached approximately 300,000 people, 160,000 from the east side of the city and 140,000 from the west side of the city, yet this number is still rising. This map here presents the discourse of displacements the IDP took outside of the city. Today I'm going to be focusing on Kayara, as we are running a secondary healthcare facility. Kayara also have major camps of displacement, including Al-Jada and Airstrip. Originally, as epidemiologists, we were there to do a survey study addressing different questions, including non-communicable diseases, mental health, and malnutrition. However, with respect to malnutrition, few assessments have been done, targeting children 6 to 59 months. For instance, in Erbil, an exhaustive assessment took place in 5 major camps of displacement, resulting in 1.8% global acute malnutrition and 0.6% severe acute malnutrition. The numbers we see in the table in front of us do not reflect a high prevalence of malnutrition. Nevertheless, in Kayara Hospital, where we are running a small intensive therapeutic feeding center counting 12 beds, we witnessed a different trend of malnutrition. First, the bed occupancy rate was high, counting up to 120. Sometimes 3 children are sharing the same bed. More importantly, 75% of these children were under 6 months, and the rest were between 6 months and 1 year. Therefore, being there and to avoid waiting for research authorizations, which will delay the response, we decided to shift our operations into a more programmatic operational activity and document our results. Therefore, we conducted a malnutrition assessment aiming at estimating the prevalence of malnutrition among children under 1 year old, stratified by age group 1 to 5 and 6 to 11 months. Also, we decided to explore the barriers to feeding children within these age groups. The malnutrition screening was exhaustive. In Al-Jada camp, section 4 and 5, the choice of section was to capture the new arrivals. The target population was children between 1 to 11 months of age. Owing to the difficulties of assessing malnutrition among children under 6 months, we decided to use weight for age Z-score. First, due to its practicality. Second, it has been used before in national health surveys, which enable us to compare our results. In addition to the weight for age Z-score, we decided to use MIWAC with a cutoff point under 110 millimeter, considered severe malnutrition, or edema. For older children, MIWAC with classical cutoff point was used in addition to edema. In addition to the screening, we had a qualitative component based on semi-structured interviews. The target group for the semi-structured interviews were mothers or caretaker of children under 6 months hospitalized in Kayara for severe acute malnutrition. In addition to key informants, and with that, for example, service providers or health workers. Today I'm going to present the preliminary results. In total, we have screened 1,389 children, resulting with 23% severe malnutrition among children under 6 months and 12% severe acute malnutrition among children between 6 and 11 months. So we did not stop at the screening. We also had a pediatrician who saw the children on site, clinically assessed the children on site. So for the children under 6 months, 91 out of 129 were assessed by the pediatrician, and 24% of those were in need of immediate hospitalization. For the older children, 69 out of 109 were seen, and 6% were in need of immediate hospitalization. That does not mean for the other children they do not require any intervention. Rather, they need more rigorous follow-up, or else they will end up like their counterparts. 61% of the severe malnourished children under 6 months were found to be exclusively breastfed. However, 68% of those were being breastfed 4 times a day or less, which associated significantly at higher odds of developing severe malnutrition. For the children who are not exclusively breastfed, the most prevalent alternative foods were formula milk, mixed breast feeding, normal cow milk, in addition to many others that were reported. Qualitatively, we conducted 15 semi-structured interviews, 8 with the caretakers and 7 with key informants. The behavior of the mother and the habits in Iraq played an important role in the feeding patterns of the children. For instance, mothers perceived that breast milk alone is not enough for the nourishment of the child. They complemented or sometimes substituted with other types of foods, including sugar and water, soup, yogurt, etc. Many others were reported. Mental health, trauma, witness to violence, also affect the mother's ability to lactate. Food inside Mosul was unavailable for the mother, which led them to believe that it affects their ability to breastfeed. In the camps, formula milk was not available for the children, and if available, it required money to be purchased, and refugees could not afford it. And here I would like to quote one of the mothers who were living in the camp, what she said: "The hardest thing is that there is no help to buy milk for my child to feed him." This study highlights a high prevalence of malnutrition among children under 6 months of age, in comparison to the national health surveys conducted in India, for instance, resulting in 13%, and in Nigeria, 10%. Operationally, we decided to increase our ITFC capacity and started an ATFC program. Mosul, Iraq, and the Middle East represent a new context for our operations. And rather than saying new context, I would say more a specific context that differ than the others where we are used to work. And with such context, the specificity of the context affects disease trends, patterns, etiologies. For instance, what we saw here, the pattern of malnutrition affecting children under 6 months. The contextual implications also do not just affect the disease or the medical conditions themselves. They also reflected on our operations, dictating flexibility to adapt our methodologies in such emergencies. Finally, I would like to close with a debate on the most appropriate intervention. Is promoting breastfeeding implying behavior change alone enough to tackle this public health issue, or should we adopt another pragmatic intervention, which includes distribution of breast milk? One, opposing both, distribution of formula milk. Opposing both interventions is a sterile debate, and one should not cancel the other nor delay feeding the malnourished. Bottom line, we should consider that every woman who chooses not to breastfeed or is unable to breastfeed have access to appropriate alternative food for her children. Thank you very much.